So a very warm welcome to this rapid report session, which showcases some of the Martin House Research Centre's superb projects. And I should emphasise it's just some of them, a small number of current projects. And I think you'll agree that the breadth of the research underway is really quite remarkable. So the 6 studies that we'll hear about today seek to address or better understand current challenges at a patient, family, staff or service level. And they employ a range of methodologies as well. So we've got systematic reviews, interviews, surveys, and a cohort study which uses population level data. So really diverse in terms of their focus and their methodological approach. The full presentations, as Lorna mentioned, are available via the link on the website. And if you haven't already seen those, I'm sure these short, rapid fire presentations will whet your appetite to go and look at the full presentations. So please do, while you're watching, use the question and answer function, and we'll explore the questions at the end when all the speakers have finished. So I'm going to hand over to Sue Picton now, who's going to introduce the individual speakers.
Hello, good morning, everybody. Thank you, Lucy. So our first speaker is Dr. Andrew Papworth, who is a research fellow at the Martin House Research Centre. Now, he's the only speaker who isn't delivering his presentation live because he had a new baby daughter just a few days ago. So his talk has been pre-recorded.
Hello, my name's Andrew Papworth and I'm a research fellow here in the Martin House Research Centre. I'm just going to be giving a quick summary of one of the studies that I've been working on for the past 2 years, which is called Switch. It's looking at staff wellbeing in children's hospices, trying to understand what organisational factors can influence staff wellbeing. This was a national study. We surveyed 583 staff across 32 hospices in the UK and the Isle of Man. And we found that 12% of participants were experiencing moderate to severe burnout. And they scored an average score of 34.6 on the Copenhagen Burnout Inventory, which is consistent with, if not slightly lower than those in other caring professions. So for example, midwives in a study in 2005, they had scores of over 40 generally. And we also found that staff in children's hospices in the UK that responded to the survey had a slightly higher engagement with their work than those working in the NHS in similar roles. So the average score in our sample was 7.47, and this compares to the NHS staff average of 7 in 2020. Thank you.
Thank you very much. We're going to keep moving on, questions and answers at the end. Our next speaker is Victoria Fisher. She's a research trainee at the Martin House Research Centre, and she's giving a talk entitled The Experiences of Fathers of Children with a Life-Limiting Condition, a Systematic Review and Qualitative Synthesis. Thank you.
Thank you. So hello everyone, I'm going to tell you about a systematic review and qualitative synthesis that I did looking at the experiences of fathers of children with a life-limiting condition. So this is important because what we know about parents of children with a life-limiting condition is generally quite biased towards the experiences of mothers. So after database searches for existing studies on the experiences of these fathers, 32 papers from 30 studies were included. And we excluded studies that sought the experiences of other family members or professionals. So thematic synthesis was used to analyse the studies, and the aim of thematic synthesis is to generate analytical themes that are more than the sum of the individual studies. So thematic synthesis led to the development of 4 analytical themes surrounding the experiences of these fathers. The first theme relates to the uncertainty introduced into fathers' lives at the time leading up to diagnosis, the diagnosis itself, and how fathers managed this uncertainty going forwards. The second theme relates to how fathers described all aspects of their lives as being affected as a result of their child's diagnosis. So things like relationships, spirituality, values and priorities. The third theme surrounds how fathers sometimes suppress their own needs and emotions out of a perception that they must be strong and supportive for others. And this role perception was sometimes reinforced when they felt sidelined by healthcare professionals. So the fourth theme surrounds the role conflicts experienced by fathers, and particularly working fathers in this review, and the often overwhelming nature of their responsibilities. So this study highlighted some of the experiences of fathers of children with a life-limiting condition and some of the challenges that they encounter. What we still don't really understand is the implications of these challenges on fathers themselves in terms of their own health and well-being. So the next stage of this research will be to look at the mental and physical health and well-being of fathers of children with a life-limiting condition. Thank you.
Thank you very much. Our next speaker is Dr. Julia Hackett, who is a research fellow at the Martin House Research Centre, is going to speak on bereaved parents' accounts of extended time with their child, a multi-site qualitative study of parents' experiences of using cooling facilities provided by children's hospices. Thanks, Julia.
Thank you. Good morning, everyone. So I'm just going to tell you a little bit about the Early Days project, which is about parents' experiences of the early days of bereavement and the support that they receive from children's hospices. So the death of a child is a profound and distressing experience faced by thousands of parents every year. Compared to other types of bereavement, parental bereavement carries the greatest risk for long-term impacts on mental and physical health. There is growing evidence that the ways parents are supported immediately after their child's death impacts outcomes. Evidence on the benefits and value to parents of spending time with their dead child following their death means that this is now integrated into routine practice. In the UK, all children's hospices offer parents the use of cooling facilities to extend the period of time before their child's body is transferred to the funeral director or their funeral. We conducted a multi-site qualitative study which explored parents' experiences of this period of time and of using a cooling facility. We completed in-depth interviews with 23 bereaved families whose child had died within the previous 18 months and had used a cooling facility provided by a UK children's hospice. We found that all parents highly valued this period of time. Using cooling facilities allowed them the time and space to begin engaging in grief work. There was clear evidence that having multiple opportunities to see their child's body supported parents' acceptance of the reality of their death. Parents believed that their initial shock and pain was somewhat softened because their child's body hadn't been immediately taken away from them. They were relatively in control of when this would happen and had time to ready themselves for it. Parents also valued being in a setting where grief was normalised and where they were supported in beginning to adjust to a world without their child. During this time, parents also made memories with and mementos of their child, and all described this as highly beneficial. In conclusion, our findings demonstrate how cooling facilities support early parental grieving processes. We suggest that every parent should be given the opportunity to use cooling facilities if they want to. This has implications for informing evidence-based practice within children's hospices and NHS services who are beginning to offer this provision. However, we found that it's important to offer individualised care, as not all parents want to use cooling facilities in the same way or the same place. Thank you.
Thanks very much, Julia. Our next speaker is Dr. Stuart Jarvis, who's a research fellow at the Martin House Research Centre, who's going to give a talk entitled Healthcare Use When People with Life-Limiting Conditions Transition to Adult Care, a Systematic Review. Thanks, Stuart.
Thank you. Good morning, everyone. So I'm presenting on a piece of research we did as a systematic review, looking at whether there was a change in healthcare use at the transition from children's to adult healthcare. We were interested in this because there's a whole body of research suggesting that there might be problems at transition. And this is nicely summed up, I think, by the quote on the right, which comes from the Care Quality Commission report, in which a young person says about the transition, "It makes me feel insecure. The GP doesn't want to see me. They want me to go to A&E. They don't have experience and training." So to do this review, we used 3 concepts in research. These were life-limiting conditions, children and young people, and transition. There's a 4th concept we didn't search because we didn't think we could use useful terms for it, which was the outcome of any health or social care use. The search found us towards 20,000 papers, and we went through a screening process to reduce these to 19 included papers, which described 18 distinct studies. These were dominated by studies from North America, but there were also studies from the United Kingdom, Germany, France, and Australia. We weren't able to do a meta-analysis, which is a common way of combining information from different studies, because the studies were too heterogeneous in terms of where they were located, how outcomes were measured, which outcomes were measured, populations included, and how it was determined whether people were in children's or adult services. So instead, we used 2 techniques called p-value combination and vote counting. I won't go into these, but these essentially allow us to look at the strength of evidence in a particular direction, so for an increase or a decrease in a particular outcome. The outcomes we looked at included outpatient attendance, where we found evidence both for an increase and a decrease in different studies. But this was patterned by country. We found evidence for a decrease in the United States and for an increase in Canada. For inpatient admissions, we also saw evidence in both directions, but again, this was patterned by country in the opposite directions. So there was an increase in the United States and a decrease in Canada. We saw evidence for more A&E visits after transition, evidence in both directions on inpatient bed days, and evidence for a decrease in the number of people in receipt of physiotherapy after transition. And again, evidence in both directions on overall costs. So a bit of a mixed picture overall in the outcomes, but another important finding from the review was that there's a common limitation in previous studies in that they tend to be either small from a single clinic or group of clinics with well-defined transition, or large population studies which might be more representative of the population with condition, but with poor ascertainment of transition, for example, using a simple age cutoff, which might mean that adults are included in the pediatric group and children included in the adult group. I'm doing some research now to try and improve on this. Thank you.
Thanks very much, Stuart. Moving on now to Dr. Jo Taylor, who's a lecturer in applied health research at the Martin House Research Centre, to give a talk entitled Polypharmacy in Children and Young People with Life-Limiting Conditions, an observational cohort study in England. Thanks, Jo.
Okay, so this is a study, as Sue mentioned, about polypharmacy for children and young people with a life-limiting condition. And polypharmacy is about taking multiple medications and the consequences of this. So first, a bit of background. So my initial interest came from work actually I've been involved in looking at polypharmacy in older people. So in particular research that's trying to sort of develop interventions to deprescribe or to stop medicines that are either harmful or no longer appropriate. And I wondered really whether this had been explored in children with life-limiting conditions. And there really isn't much beyond a few sort of North American studies and a couple of children's hospice audits from the UK, both indicating that these children do experience polypharmacy. And often this can be, appropriate. So it's highlighted in qualitative research as well, so qualitative studies with parents and through our own consultation with families and clinicians, which suggests that polypharmacy is both common but not always appropriate. So we wanted to understand whether this was the case by initially exploring the prevalence of the numbers of children who experience polypharmacy and the patterns of that polypharmacy. So for this, we analysed GP prescribing data of nearly 16,000 children and young people aged 0 to 19 diagnosed with a life-limiting condition. And there are all sorts of intricacies and challenges we encountered in terms of the flow of children in and out of the data set, how we counted and characterised prescriptions, and how we managed missing data. But overall, we started by counting the numbers of distinct and regular medications for each child for each year, running from 2000 to 2015, which you can see here in the slide. And we found that around a third of children are prescribed at least 5 different medications each year. And this is the most commonly applied definition in previous research. Around 1 in 10 children are prescribed at least 10 different medications each year. And this is recognised as a potential indicator of problematic polypharmacy, so polypharmacy that may cause some problems for children. We also found that children with a respiratory, a neurological or a metabolic diagnosis were more likely to experience polypharmacy, as were children with more than one life-limiting condition or a comorbid chronic condition, and also children from more deprived backgrounds. We presented these findings at workshops with parents and clinicians, and from these workshops we established that our study is potentially likely to underestimate polypharmacy for some children who are receiving prescriptions outside of primary care. And that while these counts provide a useful starting point, the key risk factors for problematic polypharmacy may be more about the lack of medication reviews for some children, the number of clinicians that can be involved in a child's care, and fears of stopping medicines, for example, if they've been started by someone else, if it's for a clinician, or when a child is stable with the number of medications that they're taking, and addressing tricky symptoms by adding more drugs, which sometimes can happen. So our plan really is to develop a second qualitative stage of research, that it starts to explore this in more depth, and then to use this evidence to think about what changes or new practices might be needed. Thank you.
Thank you very much. Finally, our last rapid report is from Dr. Suzanne Mukherjee, who's a research associate at the Martin House Research Centre. Is going to present a talk entitled Patient-Reported Experience Measures. Why are they needed for children and young people with life-limiting conditions? Thanks, Suzanne.
Hello, everyone. Hi. So the purpose of my presentation this morning is to introduce you to patient-reported experience measures, otherwise known as PREMs, explain what they are, why they're important or useful, and briefly tell you about our current project at the Martin House Research Centre aimed at developing a PREM for children and young people with life-limiting conditions. Now, as Richard Harding has already mentioned this morning, the project is in collaboration with the team at King's College London, who are aiming to develop an outcome measure for children, but is also quite distinct from that work. So I'm going to just begin by telling you at the most general level what patient experience is. So patient experience is quite simply what the process of receiving care feels like for the patient, their family and carers. Within the UK, but also internationally, there's broad agreement that patient experience alongside clinical effectiveness and safety are what determine the quality of patient care. Now, importantly, recent systematic reviews have found that positive patient experience is in fact associated with a range of clinical effectiveness and safety measures. So, for example, reduced pain, lower anxiety, and adherence to treatment plans. Now, there's obviously lots of different ways in which you could assess patient experience, but PREMs are questionnaires which allow us to measure patient experience quantitatively and in a systematic way. And what that means is that they can be used to identify aspects of patient care that need improvement and to evaluate the impact of service models or service improvement initiatives. Unfortunately, there are currently very few PREMs available to assess children and young people's experiences of care. And when we've looked at those that do exist, we find that they're often specific to a particular condition or a particular setting. They're often not psychometrically robust. and many of them focus on the functional rather than the relational aspects of care. So that means that they assess what people got rather than the quality of their interaction with staff. So the PREN development project currently being undertaken at the Martin House Research Centre aims to develop a brief measure of patient experience which can be used in any settings where children with any life-limiting condition receive care and treatment. Now, as Richard has also explained this morning, the development of measures such as this is extremely complex. And at the moment, our research is in its early stages. But if you are interested in this particular measure, please do keep an eye on the Martin House Research website, where we will post updates on our progress. Thank you.
Well, thank you very much to all of those speakers. It was really amazing how they all interlink in many ways. So I'm going to hand over to Lucy, who has been looking at the live question and answers.
Thanks, Sue. So we have a number of questions, and I'll start with the order in which they arrived, which obviously relates to the order of the presentations. The first one from Mike Miller relates to the switch study. So I think we might have to go to Jo in the hope she can answer this one for us. But Mike's asked, is this in the switch study? Sorry, in the switch study, were there differences between hospices, or wasn't that looked at?
So we're not looking at differences between the individual hospices, and our analysis is ongoing. But what we are going to do is to look at particular characteristics of children's hospices in terms of different ways of working and different staff models and so on. So characteristics that we know from the literature might influence staff well-being. And so the aim is to understand sort of what organisational features and staff support interventions may enhance staff wellbeing among children's hospice staff, rather than sort of looking at individual differences between individual hospices, which we think will be a more sort of useful way to use our data. Thanks, Lucy.
So a question for Julia. So in your bereaved parents study, obviously you focused on parents, but did any of them mention benefits for their other children or the wider family of having time to view the child's body?
Yeah, they did. So this was something that families talked about quite a bit, both those who used the calling facilities at home and in the hospice. So parents did talk about the benefits for their other children, so for the siblings of the child that had died, and also grandparents and friends of the family as well. And I think how parents manage that time really varies. So some very much think it's important that their other children, for example, are involved in that time and spend time with the child that had died, and others it's more of a form of protection. They think it would be better for them maybe not to, and I think that entirely differs on family, and you've got to kind of go with what they think is important. But I do think it's an incredibly important time for all people in different ways, and it would be great to explore that in more depth with a follow-on study. Thank you.
Can I just ask one more question, Julia, on that? So who do you have? I know your study was about parents that had used it, but do you know anything about the number of families that are offered it and what proportion take it up as an option?
We don't. What we would love to do is have views of parents who had been offered it and who had chosen not to, because I think that perspective is so interesting and so important, and I think it would just add so much to the conversation, really. I'm just trying to think. We do for the first stage of this study, we did a survey of all hospices in the UK, and we did ask them about take up of it. I can't quite remember the figures off the top of my head, but that is a published study. So I will come back to you on that. But yeah,
thank you.
No, it's fine. Thank you.
Can I just come in as well, Lucy, on that then? Because I was thinking, as Julia did her talk, about the alternative, which is hospital mortuaries, which are in many, many centres not where you would think any family would want their child to lay. So it is, I think that's really, really important. It may come down to very straightforward geography of where the hospice is, but what we can offer in hospital in terms of memory making after a child dies and the physical environment of the mortuary is it's just so inadequate.
Yeah, we did have some families talk about their child being in the mortuary for some period of time. So I think for the great majority, they didn't go to the mortuary, but a couple did, and it was a very different experience, definitely.
Another couple of questions have popped up, Julia, which I think we've got time to stick with you for a couple more minutes. So the next question, did your study include families where the young person who died was over 18?
It did. So our age range went up to the age of where the child had died, went up to the age of 26.
Okay, thanks. And the last one is, did you find differences in the use of cooling after death among different faith groups?
So we did have some representation in our sample of different faiths, which was really interesting. I'm just trying to think. I know what we've discussed as a team a lot is actually the importance of not making assumptions based on people's faith. So not making an assumption that just because someone is of a certain faith that they wouldn't wish to use the cooling facilities. There might be different timeframes and things that need to be known about. But I'm just we haven't explored it in terms of faith specifically, but those views are represented in our sample, yes.
Okay, thanks very much, Julia. There's actually more popping up, but we'll deal with them in the order that they arrived. So over to Victoria now. Can you tell us, Victoria, how do findings on fathers differ to previous findings on mothers?
Yeah, so much of what I found was similar to what's represented in maternal or parental literature, particularly sort of experiences around the time of diagnosis in terms of the shock, maybe uncertainty, the anxiety, and this defining a new normal, sort of the day-to-day impact of a child's condition. For fathers in this review, two things stood out really as perhaps being different. And the first is this idea of fathers feeling sidelined in healthcare settings, often not knowing how to ask for support themselves or even knowing where to sort of access support for themselves. And the second is this real conflict experienced by working fathers in this study, sort of managing workplace responsibilities with those at home, which obviously is not unique to fathers, but the majority of the fathers in this study were in employment. So that's I think those two things are going to be really important factors to consider kind of going forwards in designing the next bit.
Okay, thanks very much, Victoria. Stuart, so do you have any sense of why the findings from your review might differ in the US and Canada?
It was one of the interesting things that came up. Clearly the healthcare systems in the United States and Canada are quite different. Canada is a sort of single payer system. The United States is much more sort of different insurers. A few possible explanations. In looking at outpatient attendance in Canada, there seems to be a trend for more clinics that are specialists in a single aspect of care once you get into adult care. So you might have more different appointments with different providers than you did in childhood. So that might explain why that goes up. In the United States, it may be that some sort of state-backed insurance becomes less available when you become an adult and there's less access to outpatient appointments for that reason. In terms of inpatient admissions, there's some studies from the United States that show that those who have fewer outpatient appointments then have more inpatient admissions. So you can see that a decrease might lead to, in one might lead to an increase in another. And there might also be differences in the ways that conditions progress. So for example, if you look at cystic fibrosis, the survival times are longer in Canada, so it may just be that inpatient admissions go up more in the United States because people are having worse condition management potentially over time. But a lot of it, I think, is speculative, and it's interesting, but it needs more research.
Thanks, Stuart. And we've got a couple of questions for Jo. So, the first one is sort of discussing the impact of polypharmacy on the family and carers who spend many hours administering medications around the clock. And in your future qualitative work, do you plan to look at the care burden and impact of polypharmacy on parents?
Absolutely. I think this is going to be really important. So when you think about the wider research on polypharmacy, which, you know, like I mentioned earlier, most of it's been done around older adults who have sort of, you know, 2 or 3 chronic conditions. A lot of the sort of problematic polypharmacy comes from how drugs interact with each other, medication errors, and those more sort of clinical outcomes. And I think less is talked about in that wider literature around the sort of medication related burden or medication related quality of life for people. And I think that's absolutely critical for, you know, children and young people who will be taking multiple medications each day, and parents who are often administering these medications, sometimes as well through a gastrostomy as well. So I think this is something that we you know, is going to be central to the qualitative study that we carry out, hopefully, in our next phase of the research. So thanks for asking about that. Really, really important.
Thanks, Jo. And a further question is from Andrew Haynes, is what's next in polypharmacy research, and can we differentiate appropriate and inappropriate?
Yeah, so there is some research happening in different patient populations that are continuing to use prescribing data and, you know, developing sort of quite fancy algorithms in terms of trying to identify, you know, particular medications that may be used together and are causing side effects and unhelpful interactions and things. And again, it sort of links back to what I mentioned in terms of where that research has come from. So a very different patient population. But I think really for us, the next stage, and this really comes out of the workshops that we carried out as part of this study, which I haven't really talked much about in my presentation. You know, we wanted to look at prevalence because really that's a useful starting point. It's not something that's been done before for children with life-limiting conditions. But our workshops, that we ran 2 workshops attended by clinicians working in children's palliative care and children's, you know, other relevant NHS services and hospices, and also parents and young adults. And they talked a lot about the sort of factors that may be increasing the risk of the sort of more inappropriate or problematic polypharmacy actually not being something that we can find in prescribing data, and more around how you know, some children are cared for by multiple professionals, all of whom might be prescribing, and sometimes when that is the case, actually medication reviews aren't happening on a routine basis. So I think really where we're heading for this, but I think we need a little bit more understanding first, but where we're heading for this is, you know, towards thinking about, well, how can we make a difference? Actually, if there are children out there who are at risk, which the numbers suggest there are some, but they don't really give us much more of an indication, then what can we do about that? There's a service in it's a pilot in Liverpool, so someone that we're working with on the study, and actually just by reviewing the medications of children who come into the hospital, and thinking about which of those medications might be causing problems, or which of those medications perhaps a child's been taking for a long time and may no longer need, has been really fruitful in terms of actually de-prescribing and stopping some medicines for children. So that's something that we might be able to think about. So I think there's still lots to think about, but that's sort of where we're heading on our longer sort of journey in this topic area.
May I just come in there, because this is really, really interesting for those clinical people. And we talked about this in the hospital as well, and how it takes a lot more confidence to stop a medication actually than it does to start a medication, which is slightly perverse because often the risks are greater with starting. But I wonder how much of it's due to the seniority of the person doing that medication review, because it's hard at the weekend for more junior clinicians to stop medicines that have been started by other people. Whereas if you have a sort of consultant review of a complex patient like the ones you're talking about, I suspect they will feel much more confident in stopping things.
Yeah, and there is some qualitative research in geriatricians and pharmacists. So again, that different populations, we just don't have the evidence for children and young people with sort of complex healthcare needs. And they did find that actually some of the barriers to stopping and de-prescribing were around confidence. And that sort of barrier was definitely more of a problem for the sort of less senior or less experienced clinicians working with those patients.
I think, Jo, there's a question that relates to that and may to some extent have covered it, from Kate, which says, who do you see conducting polypharmacy reviews given the high number of clinicians involved in children's palliative care?
Now, did I see that Lorna wanted to answer this? No, I must have just seen something.
Probably.
No, I didn't.
No, you didn't. Sorry, Lorna.
Sue might want to answer it.
So yeah, I mean, it would be interesting to have your perspective, Sue, as someone who is a clinician working in this area.
Yeah, so I think it's I think that's part of the role of the specialist in palliative medicine, whether it's a hospice consultant or somebody within the hospital, because they've got the ultimate overview. Otherwise, you have different clinicians covering their different specialties, and they won't feel that they can change any medication prescribed by somebody else. So I think it is the role of an overview person, which is why this is so key. And I think families do tell us that is the biggest advantage of having this specialist palliative medicine team, that they have the confidence to oversee all the different specialties to some extent. I was very interested in how this links with Stuart's presentation on transition, because what he was telling us was that the A&E admissions go up, the acute admissions go up when patients transition, which also will no doubt link to less experienced people being involved with the care. And I wonder what impact that has on increasing prescribing during transition.
Yeah, that was highlighted in the workshops as well, actually, that young adults, as they transition, may be more at risk of that sort of problematic polypharmacy potentially not being addressed. And I've just noticed in the chat, actually, a few others agreeing that, you know, palliative care teams are perhaps well placed to be reviewing medications. And actually, it's something that they're starting to do at Bluebell Wood Children's Hospice as well. So thanks for that.
Thanks very much, Jo. We've got a question for Suzanne, and could you explain a bit more about how PREM and CPOS relate or complement each other?
Yeah, so we're working closely with the team and the CPOS team in London, and it's a kind of ongoing conversation because it's really quite complex, and sometimes the lines can feel quite blurred or hard to find a boundary. But I think we're at a point now, as Richard explained in his presentation, that the CPOS work is very much around health outcomes, but by saying health outcomes, I mean in the broadest possible sense, health and well-being outcomes, and obviously taking into account the holistic approach that's taken within paediatric palliative care. And the PREM work is about the experience of the care process. So it will look at we'll be very interested to look at the interaction with staff, because that's something that's missing in a lot of the work that's done around patient experience, particularly with children and young people. So it will be looking at things like empathetic care, compassionate care, those kind of elements of the care process. Hope that gives you some indication.
Thanks very much, Suzanne. So the final few comments really are more comments than questions. So I think we've really exhausted our questions from the audience, unless anyone else has got anything further they'd like to ask.
Can I just make one other comment?
Well, yeah, sorry, Sue.
Going back to Victoria's presentation, just my own experience of the impact of COVID on fathers' interaction with certainly patients in hospital, and I suspect it reflects also in the work that you've done, because of the use of remote technology, and how many fathers I have now been able to speak to directly from their work, because suddenly it's acceptable to do remote consultations. And I wondered what your thoughts were on that.
Yeah, it's really interesting. I suppose when we think of the impact of COVID, we obviously assume that it will all be negative. So that's, I suppose, a positive aspect of that. And I think it's just really important to consider going forwards. And when we think about recruiting fathers, which is kind of been difficult in the past, I think the remote technology kind of stuff will actually assist with that. So I think, yeah, interesting.
So thanks very much, everyone. It was a really fascinating and varied session, and stimulated a lot of discussion. And as I mentioned at the beginning, the full presentations are available via the link on the website, and I think they'll be there for some time. Is that right, Lorna?
Yes, they will. Thanks very much, Lucy and Sue and the team. We're going to have a short break now. We will start the next session bang on 11:30, so I'd encourage you to come back just a couple minutes before, but do take the opportunity to stretch your legs and get away from the screen for half an hour, have a cup of tea. But thank you, and well done, team.